Carrie, I'm not doing this again for 10 years.
She said, I'll find something else for next year.
All right.
So,
Well,
so I'm like, maybe I'll.
we appreciate you doing it. So,
Okay.
hello, welcome to our first grand rounds of 2026 fiscal year, maybe, I don't know, 2025. Yeah, yay, welcome back. Great to see everybody in person. Couple quick announcements and then we'll get into this. We have a division meeting following today's presentation. You'll also receive an email with a link to the recording of today's presentation and a copy of the PowerPoint. And in the email will be a link to the online evaluation. Please complete this. And of course, everyone in the room will get a paper evaluation. If you have any questions, submit them via chat in the Q&A box anytime during the presentation, and we will get to those likely at the end. Our next journal club date is the 11th, which I believe is next week, Thursday. And this will be on Zoom, and the presenters are Sarah Tietz and Tyson Garfield. And the next grand rounds is 2 weeks from today, and that will be Vinaya, I'm going to butcher this name, Vinaya Manchaya, and it will be emerging hearing device categories and service delivery models for individuals with mild to moderate hearing loss. So without further ado, I would like to introduce our amazing speaker today, which is Dr. Sarah Beck, and she's going to be presenting on navigating the VA system, essential insights and medication management complexities, featuring the Brave Home Meds program, which, side note, we love. And Sarah will tell you more about this. So Sarah is an associate professor in the Division of Geriatric Medicine here at CU. And she is the Geriatric Clinic Director and Assistant Chief of Medicine at the RMR VAMC, which is the VA affiliate here in CU. She works clinically as a primary care provider, and her appointment with Geriatric, with GREC, the Geriatric Research Education Clinical Center, has her working on a variety of different clinical innovation and clinical demonstration projects, such as the Falls Prevention Clinic, Healthy Aging Group Visit, and Brave Home Meds. She is a VA Site Director for the Geriatric Fellowship, and her interests include quality improvement in the VA setting. Sarah.
Right. Am I speaking loud enough? You guys ready? Okay. So I'm going to start off by giving a special thanks to my husband, Austin Beck, because he introduced me to ChatGPT image creation. And it has like changed my world. Instead of waking up in the middle of the night before a presentation and Googling images, you can create your own. And so I'll share some of the ones that I made today with you. Also wanted to give a special thanks to Robin Moon and Stephanie Hartz, who gave me feedback on slides, helped me with slides. So without further ado, we'll go ahead and get started. I wanted to give you kind of a roadmap of what I'm going to talk about today. So really how the VA works, 101, talking about Agent Orange. I think there's a lot of information out there that needs to be dispelled, and make sure that you guys as clinicians or people who interact with patients have the right information. We're going to do an update on what all of our amazing VA staff is doing. We're going to talk about medication adherence, and then I'll talk about my Brave Home Meds program. So without further ado, we'll get started. So the VA is broken down into 3 parts, and we often forget about the cemetery part. In Colorado, we have 3 national cemeteries in Denver, Los Animas, and Colorado Springs. And then we also have a memorial cemetery, which is grant funded over in the Grand Junction area. But when we talk about the VA, I really like to break the VA down into the 2 parts that are in patients' minds. I like to talk about them in reference to either the past or the present, right? So when a patient comes into my office, they are here with me in the present. I am taking care of their healthcare needs as they arise, talking about what we can do for them in the moment. The other part of the VA always has to do with the past, benefits, disability, what you experience. It's the money part of the VA. So this is so complex. I've been working for the VA for 10 years. I do not have all the answers. I always have to lean on my social work friends, learn from my colleagues about how things work, because it's constantly changing and there's a lot of rules. So we really encourage veterans, when they want to get involved in the VA, to be connected to a veteran service officer. So these are county paid free of charge to veterans to come learn about what the VA is, if they qualify, help them navigate the benefit side. And so a VSO is the first place to guide any patient to if they want to learn about the VA and what they're, what's available to them. Ooh, too far. So this is a picture of my dad. So he was in Vietnam. He was 19 years old and the draft was coming. And so he was in a tech school. And so he wouldn't be able to get some of the college deferments. And so he went and enrolled in the Air Force. 2 days before he left for Vietnam and left to go into training, he got his draft letter. So here's a picture of him. He was interested in electronics and was in a division or group that specialized in electronics. And so here's a picture of him on weed duty, which was part of his activities that he did in Vietnam. One of the things that did happen to my dad while he was in Vietnam is that he broke his nose playing softball. So when he left the military, he was asked, did anything happen to you? And he said, yep, got my nose broken. And he was service connected with a disability for a broken nose at that time. When he left the military, he started to get a disability check for $17 every month to help compensate for that, experience for him. So fast forward to today, this is a picture of my dad with my girls. This is his current disability rating now. And so since he was in Vietnam and he was later diagnosed with diabetes and heart disease, which are Agent Orange service-connected presumptive diseases, he was increased in his service connection from that 10% associated with his broken nose all the way up to 80%. Now, as you can see here, there is some VA math occurring. If you add all of these things up, it definitely equals more than 80%. And there is some calculator that a VSO probably understands that helps identify what he got service connected for. So we're going to skip ahead to Agent Orange. I don't know if a lot of you guys are familiar with kind of the history of Agent Orange, but this came out of 1962, Operation Ranch Hand and Operation Trail Dust. And so this is when we used about 20 million barrels or gallons of defoliants to help fight the Viet Cong. And so here's a picture of a river valley, and then at the bottom there's a picture of planes that were spraying these defoliants, and then the middle picture is the after effects where vegetation was killed off, and this helped part of the war efforts. Of the barrels that were made, there was actually a rainbow of barrels. There was Agent Pink, there was Agent Lavender, Agent Blue, but Agent Orange is the most kind of notorious, and it was probably about half, so 11 to 13 million of the barrels that were used were Agent Orange. And there was lots of different companies that made Agent Orange. So it was Monsanto, Dow, because it was a mad dash to, in a war effort to increase production. The main ingredients of Agent Orange are these two herbicides, the 2,4,5-T and 2,4-D. So these agents were in really high concentrations in each of these barrels. So, but what was the problem? The problem was that Agent Orange had a contaminant in it, and the contaminant is called TCDD. And so this was, it's actually a common, not common, but a formed side product in making or burning organic materials. And so this contaminant, and it's part of a class of families called dioxins, but it's not like the correct name to call this contaminant dioxin. What this does, TCDD, is it goes in via the AH receptor into all cells, it goes into the nucleus, and it helps turn on and turn off certain genes. When you have this available and interacting with your cells, it increases the activity of certain enzymes, and this can break down foreign chemicals, can also change the normal chemicals that are needed, and then excessive or persistent stimulation of this receptor can lead to adverse effects as well. So this is my first picture that I tried with ChatGPT, and I asked to kind of show TCDD going into a cell. I did have to fact check myself though, because I was like, that doesn't look like a dioxin. It doesn't have two oxygens in it. And it actually ended up being incorrect. So the true chemical structure is above. So this is my first party foul with creating my own images. But what does TCDD exposures do to the body? And so we've learned about what this contaminant does from other kind of natural disasters or experiences with this chemical. And so in Savosso, Italy, there was an accident where several kilograms of this was released from a pressure tank. Several animals died, and there was high concentration found in the children that were playing outside and eating local food. And there was acute effects. About 200 people started to have chloracnine in that area. And so that's when we really recognize that an immediate effect of TCDD exposure is chloracnine. Some of the longer term effects in this population, because of this incident, they were monitored over their lifetime, enrolled in a registry, and it was found that there was a higher prevalence of the multiple myeloma, myeloid leukemia, as well as some developmental defects associated with teeth in the girls that were born to fathers that were exposed. There's a couple other examples here that I think are important as well. So there was a workplace lab where 2 women in Vienna were exposed to TCDD, and one of the women had chloracnine for several years, and their kind of generalized symptoms were malaise and amenorrhea. There was a Ukrainian presidential candidate who was poisoned with a large dose of TCDD, and he suffered from chloracnine for many years, as you can see how it's changed his skin in the bottom picture here. And then interestingly, there was an area of Italy that was polluted by the mafia. There was kind of a trade of illegal waste dumping. And so in this area, there was a lot of these products were disposed of inappropriately, obviously. And there was an increase in liver deaths compared to the national average. So these, exposures, different things that kind of came about helped lead the charge of the VA recognizing that there was medical conditions that were associated with Agent Orange exposure. And they couldn't say like, this barrel had this much concentration of it and this barrel had little concentration of it. And so what the VA did is they said, okay, anyone that was in Vietnam, that was in other certain areas that your VSO will tell you is okay, they can get authorized to have Agent Orange exposure and get service connected for these diseases. So I highlighted here for my dad in that example is that he later developed diabetes and ischemic heart disease, and so he got service connected for these conditions. Did want to highlight here that, chloracnine, peripheral neuropathy, and porphyria, that these have to occur in the early. You have to show that like the year that you left the military, that you went to the doctors for the skin rash and you were diagnosed with chloracnine, or you had peripheral neuropathy of early onset. This is something that does get tricky for our veterans that have diabetes and complain of peripheral neuropathy later in life and ask to get it service connected, but they can't really make that connection at this point in time. There is a list on the right-hand side of different cancers that are associated with Agent Orange exposure. So now I'm moving you on to kind of learning about how it works on the day-to-day for veterans. And so all veterans, when they are interested, they come, they enroll, they've worked with their VSO, they come to our business office, and they get assigned a priority group. And that helps us determine like what level of resources that they get and copays associated with them. So in the very first priority group, patients that are rated 50% or higher, also unemployable, which is another service-connected label that we use, Medal of Honor recipients. Those are in our priority group 1. Priority group 2 is 30 to 40% service-connected disabled. 3 is 10 to 20%, but this is where we also include our prisoners of war, Purple Heart recipients, or if you were discharged for a service-connected disability. 4 is you're receiving some pension or some different benefits. Catastrophically disabled is another thing that you can work with your VSO if you get a medical condition for. 5 is no service-connected disability. So you left the military, you can't say that anything happened to you while you were there, or you did get a 0%, something happened, but it's not disabling, or you're getting a pension or you're eligible for Medicaid is 5. And then group 6 is actually something that got really expanded in the PACT Act, and I really tried to summarize it here. But this is where we have people that are 0% compensated for disability, or they were exposed to toxins. So this is really where the Agent Orange kind of come into effect. Project 112 and SHAD participants was a group of about 6,000 veterans that participated in like the late I think it was 1962 through 1973, in the US government's kind of the way that we were like evaluating biowarfare. And so tularemia was used. The ship part is on different naval ships. They were testing to see, like, did we have good response? How could we shut this stuff down? So it was really like an experience of trying to understand different chemical warfare from our side before it would happen to us. So these veterans were expanded into this priority group after the PACT Act, along with burn pits. And you can see here, there's some other service periods. And this also is an image I created in ChatGPT. And so it's not like, it's probably missing some things. Your VSO will probably be able to find an exception to get people into different categories. And then we'll kind of finish up with priority 7, which is income below the VA adjusted limits, but they agree to pay copays, or income above the VA limits and they agree to pay copays in priority group 8. And so why is this important? Is because if you get into a priority group 1, you do not have to pay for medications. That's amazing, right? That's a game changer for people. Priority groups 2 through 8 do have to pay for a copay, but it is listed here a 30-day supply. The copays, the max they would be for a tier 1 generic is $5. The max that they would pay for tier 2 would be $8, and tier 3, which are going to be our brand name medications, are $11. So this is, for people that are anticoagulants, that you see can be paying lots and lots of money, but if they come to the VA, they can get access to getting these medications for something more reasonable. Additionally, I think it's important that you guys know that service-connected disability 10% or higher will not have outpatient copays. There are copays that are associated with some priority groups, and you can see here $15, $50, or $50, but they do not have people pay for things that are screenings, colonoscopies, immunizations, lab tests, x-rays, kind of those standard things. So this is really great comparative to insurance in the real world outside the VA. So I'm going to kind of give you an example of some other things that we can do at the VA, and I'm going to tell you about this patient. This is Spring Wright and myself outside of where our fall prevention clinic is. And so we did see a Vietnam era veteran in our fall clinic. He had come in with a complaint of multiple falls. He was not using his opiates as prescribed. And so this was causing some significant distress between him and his wife. She was trying to hold on to the medications. And the way that it kind of worked out that he was taking them is he would use them all up in the first 2 weeks to be able to be functional. And then he would lay in bed for the next 2 weeks. And so, kind of really open, honest, and we went through his medication list. This is a terrifying list of 24 medications. They're all listed here. Does somebody want to shout out something that is concerning for falls? All of it. Yes. Okay. So the first thing that I did for this veteran was I provided him with a Narcan. So this is one thing that kind of is an exception to the rules in the VA when it comes to copays. All veterans that are prescribed opiates can get a Narcan annually with no charge. So that's amazing. And so if you have a veteran that you have concerned about and that becomes a cost prohibitive to get Narcan and they're a veteran, please connect them to our team. So as all good geriatricians do, we did a great functional assessment. We asked about how he's taking care of himself at home. He didn't have any cognitive concerns, but he hadn't seen the mental health department in quite some time. And so what were some of the things that we did? We connected him to the mental health department. We installed grab bars. We got him a raised toilet seat. We then were able to find a dispenser that was a lock that helped with our concerns about his medication management for his opiates. And we sent a nurse out into the home to kind of help manage that and take the strain off of his wife. So I think we were successful. But now I'm going to give another example. So this is Mr. E, and I said Mr. E because my maiden name is Earl, and this story really reminded me of my dad. And here is a ChatGPT picture that I created. And so this is also this kind of question comes from a board question that I recently did. And I'll read it to you here, or just some of the highlights. There was a 77-year-old gentleman with a UTI, fall at home, was discharged to home, told to take some antibiotics and to change his dressings. His daughter, who was out of state, came into town and had noted him being very unsteady and actually had found him the following morning after fall when he didn't want to wake her up to help him get up. Here's a medication list, and he needs help with bathing due to where the laceration is, and the daughter must return home and is worried about her dad living alone. And so the nurse is scheduled to come out for dressing changes, and the daughter asks if under Medicare, what additional help is available. So does anyone want to shout out the answer here to this question? Not C. Yes. So the answer is B, home health aid. And so under Medicare, you can send a home health aid out to a home as long as somebody is getting additional skilled needs. So here is again a picture. I just asked for the same gentleman to be in a bathroom with the nurse helping him. I'm slightly terrified by how real this picture looks. But what if Mr. E was utilizing his VA coverage? And so one of the amazing things with the VA is the support that we can provide to our older veterans. So the home health aid does not need to accompany a skilled need. And so this is a game changer for folks. It is based on a case mix calculator about hands-on care or safety and supervision, and cognitive deficits do play a role in that calculator, but we can continue to send patients out to get home health aides to help with bathing, dressing, and showering. Additionally, in the VA, at university, we can send out some skilled home health for Foley changes, wound care, other physical therapy, occupational therapy, but we can additionally send out somebody for medication help in the long term. So that's not something that is usually done at the university or through the different health insurances. And we have home health respite. So home health respite is really great for our patients that have dementia and their caregivers are a little burned out, a little tired, need a break. And so how that works is that the VA will send out through an agency somebody to come and sit with the veteran for a 6-hour period of time. And that allows the caregiver to go to book club, get their hair done, hang out in the closet, just so that they're not responsible for having to take care of the veteran that might have cognitive or safety issues. This can occur 30 times per year. It's a bucket of 30 days, and then it resets every January. So if somebody hadn't used this resource and they started using the resource now, they could use all of those 30 days between now and the end of the year. So, but what other programs are available at the VA? So one of the things that's really important when we talk about service connection is it really kind of helps you identify what resources or programs patients are available to utilize. So if Mr. E, and now he's smiling in this picture because he's learned about all of the VA resources that are available. If he was 70% service connected and needed to go into a nursing home, the VA would pay for him to go to one of our contract nursing homes. If he didn't want to go to a contract nursing home, but wanted to remain at home and there was a caregiver that lived with him or could come by very easily, we can pay that caregiver to take care of them in the home. So this is an amazing program. We also have veteran-directed care. So this is good for veterans that are not service connected, but are at that point of needing a nursing home where we can use community agencies to pay family members to take care of their family member so that they're not going into a nursing home. Other things that we have is the Community Adult Day Healthcare Program. We like to call this Vets Club instead of calling it daycare for our patients that are cognitively impaired. And so they can go to the day programs throughout the state. We have quite a few. We wish we had more though, if patients have cognitive impairment or some dependence in ADLs. Also, we do partner with PACE programs. And so if a patient is eligible for a contract nursing home through the VA will pay for them to join the PACE program. They do not follow with the VA any longer. PACE takes over and is comprehensive in their care providing. So our goal with all of these really is to avoid that first program. We don't want to pay for people to go into a nursing home. People don't want to go into a nursing home. So these are all nursing home avoidance programs. All right, so now you guys are well equipped with knowing how to get all of the resources in the VA. So I'm going to switch gears a little bit and just talk about all of our amazing team. So Here is a picture of our Geriatric team. So PAC stands for Patient Aligned Care Team. We really want veterans to get enrolled in a PAC team. And then if they, kind of meet criteria, are older and need our smaller, more intensive group, we have social work, pharmacy, nursing, all of these folks, our program support assistant to really help manage and get people what they need. Additionally, in our program, we have Stephanie Hart. So she's been around since 2010 and was a part of our HBPC program, but she is our rural social worker extraordinaire. She knows Colorado in and out and all of the locations where veterans live and some of the, sparse resources that are available to them, but she makes those connections. So she started the palliative care program as well. She is our lead for the age-friendly health systems, which she gave a great grand rounds in the past on, but just talking about how age-friendly is our way of formalizing what matters to patients, focusing on medications, focusing on mentation and mobility. And then here is our fearless leader, Dr. Larry Berg. He is holding a pig leg there, but he is our section chief. He also does primary care in our Geriatric clinic, and then he does our urban teledementia consults. So people that live in Pueblo and Colorado Springs, we do video visits to help support them as a geriatric consult. He also is the clinical reviewer for multiple things. And so state veteran homes, patients that are going to be moving into state veterans home, he reviews them for acceptance. For all of the other contract nursing homes, patients that we place in them, he is the reviewer for that. And then any patient in the state of Colorado that lives in a nursing home that does not have a primary care provider, he is the access point to say, oh, you're a veteran, you're getting care in your nursing home, but you need a wheelchair, or, oh, you need to see a cardiologist. All of the requests come through him. Additionally, he has an interest in homeless and underserved. And so we did start a homeless clinic that really was great to kind of get involved with the homeless department and kind of bridge it across our disciplines and our different teams in the VA. And now those patients have really been absorbed into Geriatric because we have identified that, it's a great place for them to get connected to all the resources. We have Dr. Karen Shea. So she is our medical director of the Pueblo CLC since 2019. She was formerly in HBPC and really helped build that HBPC team down in the southern Colorado. And she also, in the last year or so, started our Pueblo Geriatric clinic, where she's seeing patients down there that are urban and need to be seen face to face. So here are some great pictures. So this is Project Healing Waters, where they're taking some of our veterans in the CLC to go fishing. And then this was from, I think, last Friday, the veterans were taken with some volunteer groups to go to the Colorado State Fair. So they're doing some amazing things down there. Here is Dr. Carrie Hornay. She is our home-based primary care medical director, and she is our educational guru when it comes to all things home-based. She helps with the geriatric fellowship and the primary care track with that. She does home-based G-tubes, which terrifies me, but she's amazing at that, and was one of the original folks that started our aging surgical wellness team at the VA. She also is a longitudinal integrated clerkship preceptor, so seeing medical students and helping them, guide them with their journey, and then did do Geriatric in the past. And then this is our newest recruit, Dr. Hannah Shara. She really brought in our inpatient geriatric consults. She is also one of our GREC training directors, so bringing trainees of pharmacy, PT, social work, audiology. I'm probably missing someone together to kind of learn once a month about geriatrics and some case-based learning. She also does that urban teledementia consults with Dr. Berg. She's our current person in the aging surgical wellness team, does Geriatric clinic with us, and is a mentor for the Narrative Story Project at the VA, and is also a medical student preceptor. And then here's me, do a lot of things. Other things besides being the geriatric fellowship site director, one of my passions is preventative medicine. And so we actually did have a preventative medicine residency, and I was the VA site director for that. We did lose some funding in regards to the School of Public Health. And so right now it's in hiatus status, but my hopes and dreams is for the future for it to come back. And one of the things that I do want to make sure I talk about or pitch is our healthy aging group visit that we do out in the Golden Clinic. And so this brings community dwelling veterans together to just learn about their health. So we pick topics from how the lungs work. I think next week I'm talking about antioxidants, all of the things that kind of come up in just media these days. We try to bring veterans in to learn like the facts so that they can walk away feeling good about being their own health advocate. So we run that weekly. There's some exceptions to that rule, but if there's any veteran that's interested, just shoot me an email and we'll get them connected. And then here's my amazing GREC friends. There's more GREC people, and I did not get you guys all on this picture, but these are the folks that really have helped me over the past couple years in my journey in research. In the middle here, I'm going to highlight Mercy. She is our LPN who is part of our Brave Home Meds program, which I'll talk about at the end. So now I'm going to move on to some of the data here so you guys can walk away that I've talked to you about data. Medication adherence is where we're going to go next. And so I told you my passion is prevention. Heart disease is the leading cause of death globally. It's preventable. And so if we were to look at the United States, hypertension is a huge problem and that can lead to strokes. It can lead to heart attacks. And so in America, its prevalence is 50%. 50% of those people are not treated. And of the people that we are treating, 50% of them are not at goal. So there's a lot of work to be done. I looked up some other studies about people taking their medications when it comes to asthma. And in Australia, only 11% of folks were taking their daily prophylactic inhaler. So some work to do there. And then this was an interesting study. It's old. It was in the late 90s of women who were diagnosed with HIV and were put on HIV treatment. And were looking at their last 2 months before delivery about medication adherence was at 34%. And so I think, if I were to really troll the research, I hope that there was something out there about adherence. And I think things would improve when it comes to the improvement that we've had over the years when it comes to HIV treatment. But here's a meta-analysis that was really looking at a lot of patients on patients taking their medication. So this is in regards to cardiovascular disease. And if you look at primary prevention, so people that came in, had heart attacks, were put on medications, the adherence to medications was at 50% for primary prevention. When it comes at secondary, did I say that wrong? Secondary prevention, the rate was at 66%. And then this other picture here is looking at the different medications and their adherence rates as well. So here's my next journey in ChatGPT. I wanted to show the smiling doctor who discharged that patient after their heart attack with their check boxes of all of the medications that the patient should be started on. And then the terrified patient walking out of the hospital holding 4 new medications after a heart attack. And so did want to pull up this study looking at the long-term adherence of medications. And so this is actually out of Duke, which has a great database for people that have come in and had cardiovascular interventions. And what they did is they sent a survey by mail to patients and asked them to list their medications. If they didn't turn in the survey, they would do a follow-up call and ask them to list their medications, and they would prompt them, oh, are you taking aspirin? So that was a prompted response as well. And of the consistent users, 71% were taking their aspirin, 46% their beta blocker, 43% their statin. If you were to combine people that were actually taking all of the drugs that they should be, those percentages really, really went down. So there's some work to do. Here's another study that looks at self-reported medication adherence. And so when people were asked in the past month, how often did you take your medications? And so what they looked at or identified as non-adherents were the people that said most of the time, or 75%, about half the time or less than half the time. And what they identified was that the patients that were non-adherent were younger, were female, non-white, less than high school education, smokers, and depressed. And so, our 8.2 non-adherence in this study was vastly different from some of these other countries where the adherence rates were listed at 43%, 27%, or 26% in Seychelles. And so So I think we've all identified that people aren't really taking medication. So this is a big deal, right? And so the Million Hearts campaign and the FDA got together back in about 2017 and did a work group, brought people that were interested in this to kind of really identify the key factors that affect medication adherence. And I'm going to go through a couple of these with some studies for you. But as you can see, it's kind of broken down into socioeconomic factors, healthcare factors, other illness factors, therapy-related factors, and patient-related factors. And so here's some of my ChatGPT pictures that I created. So really when we're talking about like the social and economic dimension of medication non-adherence, we're looking at limited English proficiency, low health literacy, unstable conditions, lack of social support, a burdensome schedule, limited access to healthcare facilities or pharmacy or insurance, and then some of the cultural and lay beliefs associated with illness and treatment. So this is a great article that came out really looking at antihypertensive regimens in the African-American population. And it was like looking at all of the studies that had kind of been done to date. And so when it comes to social support, I wanted to dive into that a little bit more. And like, oh, if we support people socially, if we're, talking about medications and providing that support, are they going to be better at adhering to medications? And so in this study, they found that, there was 4 sub-studies that were like, yes, if we support people, they're going to do better. But additionally, there was 4 studies that said, if we support people, there's not really much change. And one of those studies was using these MEMS, which are medication event monitoring systems. And so this is a ChatGPT picture that I created of where you have a bottle cap that is used mostly in research, that when it opens, it alerts the time, and then they can correlate to people adhering to their medication regimen. But some of the summative things out of this article was that really, African-American hypertensive patients who perceived their provider communication and interaction as empathetic were more likely to participate and be adherent to their medications. So that's one of the goals that we really need to make sure that we're focusing on. So the next kind of dimension is our healthcare system. And so here's my ChatGPT images that I tried to create, looking at the patient-provider relationship. That's why I have them smiling in this picture in the upper area. That health care should be at low cost with dollar drugs in the background and short wait times. All of these things, can play a role in patient non-adherence. And so other things that, just really lack of knowledge, and lack of adherence to, or understanding the interventions that are available. I thought this was great. I tried to make the patient handout hard to understand in one of the other versions, and it changed it to be foreign and in different languages. So, so what could we do about it? So here's another study that did a pharmacy-led intervention. And so this was university affiliated. So this is in California, in the San Francisco area. It had VAs, it had university, and a community health. So kind of like what we have here, that all participated in it. It was one pharmacist and targeting low-income patients that were 50 plus and had heart failure. And so when they were enrolled in the program, they had 78.8% adherence versus usual care at 67.9%. But when the intervention ended, they did a follow-up 3 months after, and that was lost, right? So the numbers kind of post-intervention started to trend back to normal. When it came to medications, taking them on schedule, in the intervention, it was 47.2%. In the intervention it was 53.1, which was improved from the 47.2 for usual care. But in the post-intervention, the adherence rates for taking medications exactly on schedule was pretty equivalent. This is a true picture of what a MEMS can look like. This is not a ChatGPT created picture, but there's lots of different options out there, and they can be quite expensive for research. I think like $130 per cap. The bottles are $5, but each cap, and if you then there's also the costs associated with the program that the researchers need to use or pay for as well. And so we'll kind of move on to the next dimension, is really the condition related. And so if there are chronic conditions that lack symptoms, which are our big ones, right? Hypertension, dyslipidemia. People don't feel that they have those problems. That is definitely going to be playing a role in medication non-adherence. And so I wanted to highlight here this next study talking about patients that were admitted into a standard cardiac unit, cardiac ICU. So the classic 80% of admissions are heart attacks, CHF exacerbations, or arrhythmias. These patients were screened for depression and had high depression scores, and they were either in usual care or were enrolled in an intensive kind of care manager-led coordination effects on their depression, making sure they're following up with their mental health provider, making sure they're taking the medications, checking in with them. And this did show that patients that were enrolled in the program that we were assuming treating their depression and getting the resources that they needed, their adherence went up. And so then let's talk about therapy-related dimension for medication non-adherence. And so I think we all know that if you've been given a prescription for a pneumonia that's 3 times a day for 14 days, you're probably not going to finish that, or there's going to be some challenges in your schedule throughout that period of time. And so complex regimens is definitely playing a role. I did create this picture as well. This is him with a barf bag to show that he was having side effects related to it. To his medications, but he looked very sad because he couldn't go out and hang out with his friends. And so, I wanted to highlight this next study that was out of Germany that looked at pharmacy claims for adherence. And so they use the medication possession ratio. So that's really like, how many pills did you pick up from the pharmacy over the period of time that you should have been taking them? And it showed, and kind of the gold standard is you're adherent if you're over 80% of the time, you're not adherent if you're less than 80% of the time. And so I did create this picture of a person getting their medications, but they're not really being put in their mouth. And so I think, this really kind of highlights that medication adherence for these medications, diuretics were, the non-adherence was at highest for the diuretics, which I think we can all imagine if it's quite frustrating for a patient to have to pee all the time with their medications, they're less likely to take that, but better for some of the other medications that were combined diuretics and other medications. And so some of the physical factors that can play a role in medication non-adherence, we can all, think visual impairment. If you can't see the pills, you can't read the bottles, that can cause some challenges. Hearing impairment, the dexterity, if you can't pick up the pills, swallowing problems, cognitive impairment. This picture I did create, I had a caregiver that was concerned but tired. That was my prompt. But I wanted to highlight this study that came out of the Journal of Women's Health that looked at pharmacy claims, just comparing men to women. I work at the VA. I thought men were going to be worse, but this study shows me wrong, that women, if you look at each of the numbers of adherence next, the women performed less, they were less adherent to regimen. So then, talking about psychological or behavioral factors, it's really important for people to know, or to learn if people are feeling their disease, if they feel like it's impairing them. So kind of that perceived susceptibility to disease, perceived benefit of treatment. They're really understanding the reason the medication is needed. And then, here's kind of the interesting aspect of like self-efficacy, where, kind of motivation is at play. And if people are confident in their ability to take medications. And so I always really try to start the bar really low and not be like, here are your 20 new medications. If you've been out of them, let's start slow. Let's make a plan of starting things one at a time. But I think, it's really important that we be thinking about the other psychological factors that are at play when it comes to adherence. So in 2003, the World Health Organization did come up with a very long, 200 plus page document about medication adherence and what we could do about it. And so again, kind of highlighting these factors. And as you can see, I highlighted here, good patient-physician relationship, non-judgmental attitude, training and communication. These are all highlighted here. And, we're in a world today where technology is really important, and we should leverage technology to help our patients become more adherent. And so there's some categories that technology can't be at play with, socioeconomic and like the actual therapy, but there are some great resources out here. And so I did create this patient using all of those resources, with their smartwatches that we have to, buzz you when you're supposed to take your medications. There are blister packs that can, tell your doctor if you're taking them, lots of different options for pill boxes that are out in the market. As I showed in our patient example earlier, locked medication, self-dumping medications into a bottle or into a cup for patients to take. These are all available for us these days. And so, after taking you through this journey of the research that's out there, I really think it's important for us to kind of go back to our geriatric 5 M's and what matters to our patients. It's really these kind of 3 key factors that are important. So what is valuable to the patient? That's why I love asking the question, what matters? If you say your family and you want to see your grandkids, maybe we should tie your medical conditions and treating them appropriately to that, so a patient can find value. We want to make it convenient for people. We want to hopefully have things low cost, have medications delivered to their home. That's why I love the VA, because we can really kind of key in on this convenience factor. And then we have to highlight that relationship that we have for trust. So now I'm going to move on to my pilot. So Brave Home Meds, it's an acronym like all things VA. It stands for Boxed Reconciled Assistance at Veterans Home for Medications. And this is actually a cross-discipline collaborative group that we brought together to help with the problem of medications at home. And so I love this slide. This really highlights the number of veterans and the age groups that they're falling in. And so the highest, or the middle one that's kind of pointing out, is the Vietnam era veterans, and we're going to see the growth of them aging. And so we know that our veterans are growing rapidly. We know that they want to age in place, and we know that we don't want them to be hospitalized. We don't want their medical conditions to play a role in them being having to go into a nursing home. And so we really want to expand the medication management that we have at the VA. Currently, we outsource home medications where we pay an agency nurse to go into the home, and Brave Home Meds, our program, really delivers this in the home. And so this actually really started back in 2021 when we had our home health team come and describe to our fellows what home health does. And within that conversation, we were just all talking about there's got to be a better way, right? There's got to be a better way instead of the VA paying an agency. So right now, we pay about $2,000 for a nurse to go out into the home 4 times over a 2-month period to fill a veteran's pill boxes. And there's a lot of issues that are associated with that. So there's a lot of paperwork, there's a lot of orders that have to put in, there's paperwork that have to be faxed to agencies, paperwork that has to be faxed back to me for me to sign and then fax back. And a lot of that paperwork does not have valuable information in it. When I first started, I used to have my nurse check the med list that was on the home health to their VA med list. And after a couple of months of doing that, she was like, this is not a good use of my time. It was concerning to me because I was like, this is an opportunity for us to kind of catch these medication errors. But in the world that we live in, it's just not a good use of our resources. And so, there's multiple issues with the current state where we're outsourcing it. The agencies have a difficult time communicating back to the VA when there's issues, have to go through the call center, don't know if the message gets through. And veterans also do struggle with our call center too. And so, they try to utilize the agency to get information to us. And at times it can work great. And we really do love our agency partners. But I think that this is an opportunity for us to do things differently. And so that's where our program came in. So Brave Home Meds brings the VA care to the veteran. And so we're pitching it as HBPC Light, right? Where instead of having a whole interdisciplinary team coming out to the home, we're sending an LPN to go fill the pill boxes, make sure the medicines are at the home, and then we do a video visit with the geriatrician on the other end to just say, hey, this is what we need refills on. This is what's missing. He didn't take this many of the pills last time. And so we can kind of in the moment take care of the needs. Oh, he just had a fall. Does he need to go to the ER? And you can kind of do those evaluations and take care of things in the moment. So I wanted to share some of our highlights where we feel like we've been impactful on our veterans that were enrolled. So one of our veterans was a dialysis patient, and when they go to dialysis, there's often changes in the medication regimen in regard to phosphate binders. And so every time that the patient needed a change, the doctor would write the order to change the medication in the system, and it would mail more meds. So all of these bottles in this real picture, this is a real picture, were all the same medication that had built up in the home. And so by enrolling in our program, we were able to kind of move that into an area of the computer that was like, don't send any more medications. So we were able to use up his supply. Additionally, there was another veteran that we had in Brave that we were given a really short notice that he needed to take his aspirin out of his pill boxes, but he lived alone and he had vision impairment. And so he really couldn't figure out which pill it was and take it out of the pill box. So we were able to send our nurse out and communicate with the surgery team, not cancel surgery by taking the medication out and being able to move forward with that. So just on the fly, being able to communicate was really, really valuable. Here's one of my favorite stories. So this is one of our veterans that did have some cognitive impairment, was living alone. And on the first visit that we went out, we noticed there was a lot of expired and potentially unsafe medications. So this first box was the medications that we removed from the home. There was medications that were 10 plus years expired. There are some inappropriate medications like Benadryl and NyQuil that were in this elderly veteran's home. He was a bit leery of us though. He was like, oh, change. I don't want to share everything. But after we were able to do a couple more visits, on the third visit, he opened this entire closet of medications that he had, right? Some were his wife's who had passed away. They were intermixed. And so with kind of gaining rapport with him, we were able to clean out that closet and dispose of those medications appropriately. And so this is where Brave Home Meds is at right now, as a pilot, a proof of concept. We feel like we've been able to show that we can provide clinically invaluable care, that we're improving care for our veterans. But we also did a huge amount of work in the background, Dr. Yee, Tammy Anding with our home health department, really looking at how we can identify the cost savings that we could do. And so we're still pitching it to leadership. It's not the greatest time era when you're asking for more FTE, but we did make it to Shark Tank. We didn't win, but we were one of the finalists for the National VA Shark Tank last year, where we could kind of come and share our program. So Brave Home Meds, it's out there. We're still doing the work. We're trying really hard. We have some great commitment from new leadership and our partners in the home-based primary care. Dr. Hornay, Kurt Class are really helping us move forward with trying to get FTE for the next budgeting cycle. So our veterans love it. They have some great comments here. And I wanted to kind of end with some bloopers. So these were my ChatGPT that I started with. And as you can see in one version, this guy has 2 arms. In the other picture here, you can kind of see just some fingers. They're not attached to the body. I had the hardest time. I tried like 3 different versions to try to show you guys or visualize that the medication adherence schedule, like with pharmacy claims, but it could not understand like what a calendar looked like and make the dates right. And then here is a true picture in the upper right of my family. It is September now. We're going to be going to Oktoberfest. So I asked us to be in Oktoberfest gear in the bottom. And so don't believe anything you see online from this moment forward, if I haven't taught you anything. But thanks for listening. Any questions, comments?
Thanks, Sarah. Fantastic presentation. Sarah undersold her Brave Home Meds. This program was one of the only one from VISN 19, so our 5-state region that was selected to go to National VA Shark Tank. And it was voted the #2 most innovative program in the entire VA. So this is a big program that benefits veterans, but also, if implemented, will reduce costs. So that's a win all the way around. So big, big props on this program. Questions?
Uh, Sarah, great talk. And I guess this is a comment, maybe there's a question in there, but I just remember growing up, because I'm really old, that my stepdad, who was in Vietnam, was battling with the VA over Agent Orange exposure and some of his disabilities, where they denied that there was anything connected there. He got his hands on some documents. I remember him showing me, he's like, I got this from some general, don't tell anyone, nobody knows I have this. But he also then had, you know, after Vietnam, he worked on the railway, transferring like taconite from the Iron Range area in Minnesota. And so it was trying to dissociate his exposure to, you know, the taconite and other things that are on the railway from being exposed to Agent Orange, and just how long of a battle it took. And he's still alive. I don't know how he is, because he's been, you know, living with these disabilities for, well, how old am I now? I'm 20. So about, you know, about 30 years, 40 years. And his body's just riddled with cancer, you know, and he can barely walk. And he also has PTSD and the whole work. So,
Yeah, thanks for sharing that. You know, I think your family member's story, he's not alone, right? I think that it's really important to highlight that in the very beginning, when people came back from Vietnam, there was no, it wasn't associated, right? But you know, with the PACT Act that came out more recently, we are really in the VA, you know, government are really trying to show ownership for those exposures. And so I would strongly encourage your family member to get a VSO in their county. It's free, and you shouldn't pay. You should never have like veterans pay a company to file their claim for them. There's a lot of kind of those sharks out there that can prey on that vulnerability, or people that feel like they haven't been successful. But our veteran service officers are trained. The counties pay for them, and they should make a meeting and talk about their service. You can bring pictures in from like where you were, like my dad having the picture of weed duty. If they were saying, you know, at the time we're saying, oh, you didn't participate, people having pictures of where they were, or if they had an injury, that's really helpful for their case. If they went to a doctor that was not VA after they were discharged and complained about their conditions, they can use that evidence to kind of help their claim as well. And so it doesn't matter, they can start now. You do get back pay from the date that you file a claim. And so even though it can take 6 months for a claim to go through, patients will get paid that back pay for them. So strongly encourage them to connect to the VA. I think we're really trying hard to serve our veterans and to get them what they need. And we, although there was like a lot of court battles and, you know, Monsanto, Dow Industries, like settlements, and there's still some challenges associated with Vietnamese folks trying to get claims for Agent Orange exposure or those defoliant exposures as well. So it's not, it is still riddled with those concerns, but what we can do now is we can have your family member get connected to a veteran service officer and then get into the VA and see a doctor team, see a PAC team to help them get connected to all of the resources that we can help them with.
As I'm walking, I'm going to ask you, can you comment on inpatient costs to veterans? You mentioned outpatient. What about if they have a hospital stay?
You need to talk to billing because I'm a doctor, but but I would say that it really it's determined based on their priority group. So there are copays of certain days for higher priority groups. So it is individualized to each veteran. Don't quote me, but I think people that are in the priority group 1 maybe without copays. And if any of my social workers are listening, they can chime in. Go ahead.
Hey, thanks for this talk. I've cared for a couple veterans on the ACE unit here in university and had to really fight the internal system to say, actually, we can probably send this person home we need to just liaise better with the VA with regards to what we can set up. But oftentimes, that there's such a communication failure, I feel like, just at that boundary, even though many of us work or have worked on both sides. I'm just curious to know how you've been thinking about that, or if that's come up at all. Are you seeing that more often with Mission Act and that sort of thing? And also, how are we thinking about this sort of inpatient to outpatient transition for veterans where
Yeah.
services are possible, but then the inpatient doesn't know anything about them?
Right, right. So I would say the call center has its challenges, but it is going to be any outsider's access to the VA. So it's 303-399-8020. The first person that picks up is going to be a secretarial administrative assistant. And you say, I have this veteran with this last four who I am calling from this number, and I want them to get connected for post-discharge follow-up, and they're going to need home health, they're going to need a walker, they're going to need different things. When the call center will then put a note in that patient's chart, and if they are assigned to a packed team, there is an outpatient doctor on the other side that will help coordinate and place those orders. There often are times where veterans are not enrolled though, or they're not assigned to a PAC team. And so we in geriatrics, myself, Dr. Burt, like all of our team can help you. I know Kate and other people have sent me emails and said, hey, I have this veteran with this last four. Can you work to see if they can get connected? And we can look them up, get back to you, and help connect you to the resources as well. But the go-to, so I don't have to do that for everyone, is to call the call center and say the veteran's name and last four. I would, working in the VA, communication has an opportunity for improvement, but there is systems at play, and we can work the system to get the patients what they need. And so it's just getting them in the door. If you know a veteran that isn't accessing resources, you tell them to stop at the business center. You tell them to find a VSO, and they will get them connected. Might take some time, but we'll do it.
I see 7 comments on chat. Are there any questions that are?
Oh, thanks.
Any last questions? All right. Thank you, Dr.
Thanks.
Beck.
Oh, I do want to, one last thing. I do want to make a pitch where, funding is really hard. FTE is really hard. There's a lot of question marks for the future for us, but I do have some hopes for next budget cycle for physician FTE at the VA. And so if there's a geriatrician that you know that is interested and wants to join our department, I have really high hopes for this coming year to recruit some more. So send their resume my way.